Buongiorno a tutti e molto grazie per invitare mio a Milano. That's all of the Italian you will hear from me today. Thank you very much for the invitation. I'm very, very happy to be here. I've been quite some times, actually very often to Italy, and I remember seeing this movie that I was here in Milano with my good friend Elio Scarpini, I think 10, 12 years ago, and we were sitting together in the outpatient clinic. At that time, there were patients he saw with dementia, and the word Alzheimer could not be mentioned. And I said to him, why don't you say to the patient, he has Alzheimer's disease? No, that's too dangerous. We cannot say this. Dementia is good enough. Now I hear in this movie, people talk open about Alzheimer's disease and all the other forms of dementia. I think that is extremely important. Awareness, knowing about the disease, calling the disease by what it is the first step in ultimately curing the disease. And I really think and hope that from now, in 10 years' time, we will be far better off in treating Alzheimer's disease and hopefully also the other dementias. Before that to happen, you need a lot of research and you need strategies in every country to do this and also to collaborate. And I think that is the history of the Delta Plan of the Netherlands. And I happen to be fortunate enough to be there from the start. We invented it, the plan, in 2011, and I'm still actively involved with it. Now, let's see. So, at that time, this was 2011, we saw in the Netherlands, which is a country, small country, 17 million people, 17, and we have 250,000 people with dementia, at least, but probably more, because the diagnosis is still not often made. We saw that the prevalence is increasing in 2011. The costs associated with dementia are extremely high, also in the Netherlands, because many of the patients ultimately need intensive sort of care in nursing homes and specialized homes, which is expensive. We have calculated that in 2011 we already spent 7 billion euros to dementia overall, and that is a lot, and that's the highest cost over healthcare in total. We also noticed that each patient, of course, has a lot of caregivers around him, a father, a mother, or a spouse, a husband, a wife, or children. That can take care of the patients. The Alzheimer the Netherlands, the Alzheimer Association of the Netherlands, calculated that there were at least 3 on average on each patient. So if you think that there will be 500,000 patients between now and 2040, you will need 3 times as many caregivers at that time, which is extremely many compared to the amount of people that we have in Holland. Also, you see that the amount of people with dementia is increasing. You see the amount of caregivers is increasing. But you see also a decrease in the amount of people who are economically active because we get less and less children. Also in the Netherlands, we face the problem of not enough children being born. So there are less people who will be caring for those who will become demented later. And of course, also we saw that the Joint Programming Neurodegenerative Disease, which is a pan-European program for research, all the 28 countries at that time participate in making the agenda for research, and each country has to participate with his own funds. And we were very afraid that in 2011 we saw this coming, that the Netherlands would not be able to participate because there was no funding for research for dementia only. So those were the sort of the background and the problems in 2011. We also looked around and we saw examples of other countries in the world having national plans. You shouldn't read this, but for instance, France or even South Korea, and there were many countries at that same time, 2008 here, that were already starting to have national plans. And especially in France, President Sarkozy has made a real effort to promote Alzheimer's disease for research, but also for care. And they spent 1.2 billion euros in 2008 for the national plan, the Sarkozy plan in France, which is a 1.6, sorry. So which is a lot of money. Well, we thought, what can we do in the Netherlands? And we are, of course, a small country, as I said. We have a history of fighting the water, because all of the Netherlands is very low, as you know, and if we don't do anything, if there are no dikes, we would have been flooded already, and if we don't increase the dikes, we will be flooded in 10 years' time if the increase of the sea level goes on. So in 1957 already, we decided to build dikes all over the Netherlands. And this was called the Delta Plan, to fight the water. And this was actually just finished in 2012. So the Netherlands is now protected for the next 50 years with the increasing water. So we will be dry. We'll have dry feet. And this is just one of the last big sort of dikes we built, and bridges, etc. You should come to the Netherlands and see this. It's fascinating. So we thought we need a Delta Plan to fight the epidemic or the tsunami, some people say, of dementia. We should fight it. So we build a dike against dementia. How do we do this? We combine all the innovative power in research and in care, and also in businesses and companies. We do this in a public and private combination. So not only from the state above, but also the companies, and also the care organization, the universities, sort of banks and businesses. Everybody should join in and donate and spend money on research. So together we built the dike against dementia. And these were the first 4 organizations that started the Delta Plan. So this is my center. This is the organization of the Federation of the 8 medical universities in the Netherlands. This is the funding organization, the Medical Research Council in the Netherlands. And this is the Alzheimer Association of the Netherlands. So 4 groups, so 4 people, and I was leading that group of people. So we decided to make a plan. And what was the strategy? We wanted to, in the Dutch we say we want to control the disease, and we also want to control the costs of the disease, because it was already staggering, and if we can't pay it, it will be a problem. So keep control over the costs, try to flatten maybe the increase in new patients. So try to, instead of going this way, maybe by research we can try to sort of lower the increase of new patients. Also increase funding for dedicated dementia research. Also increase the quality of care for the patients. The care already in the Netherlands is quite good, I can say, but we have to increase it even. And also, what is happening in the Netherlands, we are more focusing on care at home instead of in nursing homes. We are actually closing nursing homes, and people have to stay longer at home. So you have to increase the quality of the care at home. We thought about a national public-private approach for the patients that are living here today, but also with an eye on the patients for the next 10 years or 20 years. At the first outset of the plan in 2012, we thought, well, we like to invest in e-health. So we like to go to the patients at home through computer. We like to help them with advice and information through e-health. And also to be able, everybody in the Netherlands has a computer. 80% of the people in the Netherlands is connected to a computer. So to try to sort of increase the amount of care giving through e-health. And also what we didn't have in the Netherlands, and maybe not even in Italy, is a registration. So we don't even exactly know which patient is treated by which physician for how long and with what sort of medication. So we have no real clue of how the care and the cure is organized in the Netherlands for each and every dementia patient, which is completely different from oncology, for instance. Oncology is very well organized. They have registries for oncology patients in every sort of type of tumor. So we wanted to have that also to be able to improve care by knowing exactly who is giving what care to which patient. And of course a research program. And we thought it would give us more health benefit. We should also think for economic growth. So if you do research, there will be more jobs. If you invest in better care, there will be more jobs. And perhaps also try to decrease the burden on the caregivers and on the society. And what we also face is a lot of caregivers, by taking care of their relatives, they cannot work. So there is loss of productivity. So if you increase the care for the caregivers also, they may be able to have a job and also care for their father or their mother at the same time. So we are facing a loss of productivity because caregivers just can't work. So in Holland, if you go to the state, to the minister or the secretary of health, you say, I want to have money. He says, well, show me your business plan. What do you think if I spend millions of euros in your plan, what will I gain at the end? So this is, of course, very difficult. And you have to do like this a little bit and say, well, I'm not sure. But what we assumed is if by investing in the plan, research and care, if we can just have a decrease of the new patients with 20% only, and if we try to have patients not in nursing homes but more in care at home, so it's now 70%, if we increase that from 70 to 75%, that will immediately result in lowering of costs. So this is so we assumed in 2020, the end of the plan, 2020, there will be less formal costs, there will be less pressure on caregivers, and there will be economic growth. But this we couldn't even think, so we didn't even put a number there. But we already, with this, we assumed that over the whole course of the 8-year plan, we would have saved 3 billion euros. That's not a small amount of money. You would save just by spending on research, spending on care. You could actually save money because you don't spend it on healthcare and you don't spend it on loss of productivity. This is, of course, very difficult to prove, but yeah, you have to do something. So we went to the Ministry of Health. And I must say, and this is really honest, what really helped is that both the Minister of Health and the Secretary of Health both had experience with dementia in the family. So the father of our Minister of Health has Lewy body dementia. The mother of our State Secretary of Health has Alzheimer's disease. So they know exactly what is the problem. They know exactly how difficult it is to care. That is by chance, that is a coincidence. But it also tells you how extremely important awareness is. Famous people, the Queen, the President, name it. If they come out and say Alzheimer is a real problem, it helps. So for us that was a bit of a fortunate situation. But of course, the secretaries just cannot say, my mother has dementia, so I will give you 30 million. That's not the case. But it helps. So we asked actually for a lot of money, and we didn't know exactly what they would give. But in March 2013, the government decided to spend 32 million for the first 4 years of the plan. And to our surprise, they actually said, you have to spend this on research only. So not on care, not on the e-health, not on the registry, but only on research. I, as a researcher, was very happy, but it wasn't even my intention to do this. We had also We also had 500,000 to set up the organization, to a website, etc., etc. We asked the independent research organization, so the Medical Research Council, to organize the care. So the money was given to the Medical Research Council and to put up a program for research. And interestingly and important, and maybe that's also something for you to discover, in planning the research, in judging about the research proposals that I submit or my colleagues submit, there is always a patient panel involved. Building the program, making the program, and judging the program, there are always patients and caregivers involved. That's perhaps very modern, maybe very Dutch, but it's very interesting. The choices that patients make. You would say, if you ask the patients, what do you need to spend money on? Oh, better care. No. The patients say, spend it on research. We want new drugs. We want therapies. Surprising, but they say it. We also, within that budget, we had 3 million euro to spend on the JP&D, which is very nice, so we could collaborate with our European colleagues, and we have very successful programs with Italy as well. So this is how it looks, and we changed a little bit the program in 2013 and 14, because we discovered that e-health and the registry was really very difficult to do this in a short period of time. So we said, let's tweak it a little bit. So what we did, actually, we changed it into, of course, research. We are focusing on innovative care models. Again, more care at home, less formal care in institutions, and social innovation. And this is what you have as well, dementia-friendly society. Those are now the 3 pillars, so we tweaked them a little bit. Within the innovative care, there is the registry and e-health, of course, included there. But this is now the 3 models. We have what is called a cooperative, a co-op kind of setup. So we have members, and the members of the Delta Plan co-op can be universities, medical centers, the Alzheimer Association, the businesses, insurance companies, banks, what have you. All sorts. We have now more than 30 members that pay also a fee to be a member, and they also work together to make this plan happen in the next 8 years. The aim for us, when I started, I said I want to have 200 million euros in 8 years. We started with 32. We attracted private money with the 32, at least 8 million extra, so we are at 40 million. And the next phase, which will be announced next week, will include another 40 million euros by the state and by the private investors. So we are halfway, 80 million already. So this is the research program. We have actually, so we focus on the patient of today, we focus on the patient of tomorrow. We have 4 themes. A theme on causes and mechanism of disease. So what is the cause? How do you treat Alzheimer's disease if you don't know the cause exactly? So fundamental, basic research. Research on better diagnosis, better markers for diagnosis, easier markers, cheaper markers. A program on treatment and prevention, and a program on efficient care. And these, we didn't just make them up. We carefully looked at the joint programming agenda, and we actually tailored our program to that agenda. And also our Dutch Alzheimer Association, like Alzheimer Italy, they have their own program, and we sort of copied that into this whole program. So we have now one overarching research program for dementia in the Netherlands. These 4 themes. Basic science, diagnose, prognose, treatment and prevention, as I said. So we started in 2013. At the end of 2016, all the programs are running now. We invested almost 32 million in joint programming programs and different calls. We have 97 projects now, including 27 JP&D projects. Budget of the project is 150,000 euros to 1.5 million euros per project, and duration is between 2 years and 4 years. So some projects are now just finishing, and some projects will still continue. And the second round, as I said, will be announced next week, and we have very, very good hope and information that we will have another 40 million euros to spend for the next 4 years. These are just examples. You can go to the website. This is a very basic UPR in the cell-to-cell spreading of tau pathology. This is one basic science program. This is a very nice program. This is Alzheimer biomarkers in daily practice. This is a project that actually involves not only our university medical center, but a lot of private and non-academic centers in the Netherlands. We want to know how people in the field geriatricians, neurologists, psychiatrists, how they work with biomarkers, CSF, MRI, and PET, and how they discuss the options with the patients, how they involve the patients in deciding yes or no a lumbar puncture, and how they communicate the results to the patients and the caregivers. So this is a very practice-oriented program. And we will learn the value of biomarkers in general practice. Not only in my center, because I know how to do it and everybody gets an LP, but it's a totally different world outside the University Medical Center, into the real world. And this is on the fourth theme. This is on looking at formal care, comparing formal care in the Netherlands to formal care in a lot of other, and this is a program of Maastricht together with several other groups in the Netherlands and also with Italian groups, to look at differences in formal care between each European country. There are huge differences, I guess, between the care that you give in Italy to a demented individual versus the care in Holland. And maybe we can learn from each other. What is the best practice to do it? So this is that program. So, and the last thing we really started now, and I saw that you started also, is social innovation. Dementia Friends. And this is our state secretary. This is Martin van Rijn, as I told you. And he opened, we had a EU 2016. The Netherlands was president of the EU for 6 months, in the first 6 months of 2016. We organized a conference on May 8 and May 9. And he opened the website, Samen Dementievriendelijk, which is together dementia friendly, that people can actually go online and register themselves, do a teaching course to be a dementia friend, with a couple of easy questions and some less easy is how do you recognize dementia when you meet somebody at the street? How do you handle somebody who is confused on the street or in the bus or whatever? And if you follow that course, you become a dementia friend and you get this pin. This is a forget-me-not, and you wear it proudly. The aim is to have ultimately maybe 1 million dementia friends at the end of the program in 2020. Perhaps most interestingly of this whole program is how we do it with companies. So we have a bus company, and we have Albert Heijn, which is a supermarket chain. You know Standa? Does it still exist? No? Oh, it doesn't exist anymore. Okay. Another big supermarket company like we have in the Netherlands. We train the people that work in these supermarkets or shops, and we train them how to recognize a confused patient. A patient who comes in and buys coffee for the 3rd time that day, or a patient who forgets his PIN code when he is paying all the time and then it blocks. So maybe you should take him apart and maybe help him and maybe guide him a little bit, or her. So they are becoming dementia-friendly shops, and they get a sign on the wall and they say, this is a dementia-friendly shop. And they have organized, they have trained their personnel to be dementia-friendly. So this is all in the part of the dementia-friendly society, Dementia Friends. We have now also, as you have, dementia-friendly communities, towns, and Amsterdam, which is a big town, has the ambition to become the first real European big town in 2020 who is completely dementia-friendly. So, what do we have next? We are working with members. So, and that's also unique. So it's not only the state that pays from above. It's also the community that is engaged. As I said, companies, insurance companies, etc. And they can put this. We are working together on the Delta Plan of Dementia. And they have to sign a charter. And the members are convinced that dementia is manageable. Solutions are made possible by combining strength, improvement of prevention, treatment and care is possible. You have to believe it, of course. And they work by active participation. So we have meetings that the members meet, they exchange ideas, they make plans together, they do projects together, and they may help to research projects or they do sort of care projects. And they pay a little fee, 10,000 euros per year. And for some of the organizations who cannot pay that, we have a lower fee. But with this, we have 32 members now, I think. We have also to cover our administration cost, and that works really fine. So we're, in fact, we're independent now of the state, and only the state gives the money for research, but the rest we do ourselves. So the Dementia Friendly Society is completely paid by the members and the Alzheimer Association, of course. And also the improvement of care is paid by the healthcare providers, by the healthcare professionals, and not by the state anymore. So we're independent. For research, we get money. So, I think we're halfway, as we say. We started officially in 2013, end of 2016. We're almost 4 years. We'll end in 2020. And by coincidence, in 2020, the AAIC, the World Dementia Conference, will be held in Amsterdam. And we hope to be able to communicate the results of our whole plan of 8 years in terms of how we did with research, what did we achieve in care improvement, etc. I think it's very important that it creates increase for us in activity of research on the EU level, but also the national level, helps increasing awareness, as I said, and it improves the care for the patients of today and also for tomorrow. We already noticed that it serves, the plan itself serves as a national sounding board. So a couple of months ago, we had a big problem with case managers, and the healthcare providers didn't want to pay for case managers. But then the minister said to us, you are the national Delta plan. You have all the members, you have all the parties. You solve it for us. And we did. And we got all the partners together, the healthcare providers, the healthcare professionals, case managers, etc. We sat together and we made an action plan to improve case management. So also the government now recognizes us as being an important player in that field. I think that's all. Thank you very much. Are there questions or no questions?
Avete domande? C'è qualche domanda? How it is possible to decrease the number of the persons?
It's not decreasing the number of patients you have, it's decreasing the increase. So it's decreasing, in fact, the incidence of dementia. So the incidence of dementia can be decreased by giving better prevention measures. That's what we know already. And by taking better care of patients, maybe in the early stage. And then by that way, you decrease the amount of real prevalent dementia at the end. Yeah?